Okay, let's unpack this. Welcome back to the deep dive, where we take a monumental stack of clinical sources and turn them into actionable, crystal clear knowledge.
Hmm.
Today, we are undertaking a deep dive into one of the most critical and varied areas of clinical care: gastrointestinal bleeds.
A huge topic.
It really is. This is a topic that spans the entire spectrum,
Mhm.
from a quiet chronic irritation that's managed by dietary changes to a full-blown rapid response life or death emergency.
Right. One that demands immediate surgical intervention.
That's absolutely right. And for you, the learner, our mission today is to synthesize the clinical management of these conditions, specifically focusing on the nursing perspective.
Okay.
We're really drilling down into the critical role of assessment, the immediate, rapid interventions that save lives, and the often overlooked but crucial patient teaching that dictates long-term success.
Whether we are dealing with chronic reflux or an acute hemorrhage.
Yeah, exactly. It covers all of it. So to make sense of the vast twisting geography of the GI tract, we need one key anatomical marker, one dividing line that sort of separates the battlefield.
Mhm.
And that marker is the ligament of Treitz.
The ligament of Treitz, it's so important.
So this ligament, it marks the juncture between the duodenum and the jejunum, everything proximal to that ligament. So the esophagus, the stomach, the first part of the small intestine, that's considered the source of an upper GI bleed.
Right. The peptic ulcer disease, PD or gastritis,
Yes.
or esophageal varices, those are your big upper GI culprits.
And on the other hand,
And conversely, everything distal to that ligament, so the rest of the small bowel, the colon, and the rectum, that's considered a lower GI bleed source.
okay.
And this category typically includes things like diverticular disease, inflammatory bowel disease, IBD, and colorectal cancer.
Yeah.
This division is, well, it's just paramount because the location of the bleed fundamentally changes the clinical presentation.
It dictates the entire initial diagnostic approach.
The whole thing, yes.
So let's establish the diagnostic language right away, because the appearance of the blood, it really tells a story about its journey, doesn't it?
It absolutely does.
What are the general clinical manifestations that immediately signal a GI bleed is happening?
Well, we look for three primary indicators.
Yeah.
First, hematemesis, which is just, vomiting blood. This is unequivocally an upper GI source.
Right, no question.
No question. And it can appear as bright red blood, which indicates a very rapid, fresh, and often massive bleed that hasn't had time to interact with stomach acid.
Okay.
Or it presents as the classic coffee ground emesis, and this is the critical nuance.
Yeah.
The blood has been partially digested, turning it brown and granular because of that interaction with hydrochloric acid.
And what about the assessment findings further down the line? How do we distinguish, say, a slower upper bleed from a true lower GI source?
That's where transit time comes into play. So
Yeah.
second, we have melena,
Okay, Melena.
which is the black, tarry, sticky stool, often described clinically as having the consistency of, like, roof tar. Melena almost always points to an upper GI bleed. And that's because it takes a significant amount of time, often 50 to 100 milliliters of blood loss digested over several days, for the blood to break down and oxidize as it travels through the intestines.
But wait, you said Melena is almost always upper GI. If a massive upper GI bleed is rushing through the system too fast, wouldn't that look like bright red blood even though it started proximally?
Yes.
How do clinicians quickly differentiate that from a true lower GI source?
That is a brilliant point, and it's a critical challenge at the bedside. Yes, if an upper GI bleed is massive enough, it causes extremely rapid peristalsis, and the blood doesn't have time to fully oxidize.
So it comes out looking red.
It can exit as bright red blood hematochezia.
However,
Even in those cases, the patient presentation is usually much more severe, much more rapid in its onset than a typical lower GI bleed. We're also looking at all the associated systemic signs.
which are the third and, arguably the most important set of assessment findings.
Precisely. Beyond the visible blood, the systemic signs of hypoperfusion tachycardia, so a rapid heart rate, hypotension, low blood pressure, and dropping hemoglobin and hematocrit, these are the signals that scream massive blood loss and hypovolemic shock.
And that's the real emergency.
That's the emergency. And remember, tachycardia is often the earliest compensatory mechanism. If a patient is bleeding, their heart rate will jump to maintain cardiac output, often way before the blood pressure crashes. Nursing vigilance on the vital signs is the first non-negotiable step.
Okay, let's start where many chronic GI issues begin: reflux, or gastroesophageal reflux disease, GERD. If the entire GI system is a plumbing network, GERD is the gate problem.
That's a good way to put it.
Our sources define GERD not as a single disease, but as a syndrome resulting from the lower esophageal defenses being overwhelmed by acidic gastric contents. The core mechanical failure here is the incompetence of the lower esophageal sphincter, or LES.
Right. That LES is designed to be a highly pressurized one-way valve. It's supposed to maintain a higher pressure in the distal esophagus than in the stomach to prevent backflow.
But it fails.
It fails. When the LES pressure chronically decreases, often due to high fat intake, certain medications, or just structural weakness, the higher pressure gastric contents reflux effortlessly back into the esophagus, an area not built to handle that level of corrosive acidity.
And those contents aren't just HCl, are they?
No, it's a potent cocktail. It includes acidic gastric secretions, the highly corrosive gastric enzyme pepsin, and often intestinal enzymes like trypsin and bile salts. This chemical barrage results in significant irritation and inflammation.
Medically known as esophagitis.
Exactly. And this chronic inflammation is the gateway to more serious issues.
So when assessing a patient, what are the specific clinical manifestations, beyond the colloquial heartburn that a sharp clinician needs to identify?
Well, the clinical term for heartburn is pyrosis, and while it's the most common symptom, we need to go deeper. Patients describe it as a burning, tight sensation. It starts beneath the lower sternum and spreads upward.
And it can radiate, right?
Oh, yeah. Sometimes, alarmingly, all the way to the throat, jaw, or back. It's often worse after ingesting trigger foods or when lying down.
And crucially, what about the non-traditional symptoms, the ones that might mislead a diagnosis into being purely respiratory? This is a huge teaching point for patient assessment.
This is a key nursing assessment area because many patients are first diagnosed with atypical asthma or a chronic cough.
Really?
Absolutely. We need to assess specifically for respiratory and otolaryngological gynecological symptoms. These include unexplained wheezing, persistent coughing, and dyspnea, often caused by microaspiration of gastric secretions into the upper airway.
Wow.
Otolaryngological signs include hoarseness, a chronic sore throat, a globus sensation, that's that persistent, uncomfortable feeling of a lump in the throat, and recurrent choking episodes, especially at night. We also need to assess for signs of delayed gastric emptying, like early satiety, bloating, nausea, and vomiting, which can all contribute to that reflux pressure.
So if it's left unchecked, GERD isn't just uncomfortable, it fundamentally changes the tissue. What are the major complications we're actively trying to prevent through rigorous patient care and education?
Well, the initial complication is chronic esophagitis. Repeated acid exposure causes scar tissue formation, which is non-elastic. It decreases the distensibility of the esophagus.
And that leads to a stricture.
Exactly. An esophageal stricture, which in turn causes dysphagia or difficulty swallowing. Patients may report food sticking on its way down.
And then there's the complication that really ratchets up the cancer risk. Barrett's esophagus.
This is the precancerous lesion requiring chronic monitoring. The pathology is, well, it's fascinating and terrifying. The normal, protective, stratified squamous epithelium of the esophagus is replaced with abnormal columnar epithelium. It's a process called metaplasia.
A cellular change.
A direct adaptation, or rather, a failure in response to chronic acid injury. Once Barrett's is identified via endoscopy and biopsy, the patient requires vigilant chronic surveillance endoscopy because their lifetime risk of developing esophageal adenocarcinoma is significantly elevated.
And you can't forget the acute respiratory issues.
Never. Acute complications like bronchospasm and aspiration pneumonia must be constantly guarded against, particularly in hospitalized patients who are supine.
So this all underscores the tremendous value of comprehensive patient teaching, doesn't it? For mild to moderate GERD, first-line management is non-pharmacological.
Absolutely. This is where the nurse becomes the patient's primary educator and advocate.
So let's focus on the mechanics. Gravity and timing. What are the specific actionable items that must be communicated clearly to the patient?
We leverage gravity to reduce that pressure gradient that allows reflux. So specific teaching points include elevating the head of the bed 6 to 8 inches.
And not just with pillows.
No, we stress that. It must be done using blocks or a foam wedge under the mattress, not just stacking pillows, because pillows only flex the neck and can actually increase intra-abdominal pressure.
Which is counterproductive.
Totally counterproductive.
Mm.
Crucially, the patient must avoid lying down for 2 to 3 hours after meals to allow gastric emptying before the supine position increases risk.
Okay.
We also recommend eating small, frequent meals rather than large, pressure-inducing meals and avoiding late-night snacking altogether.
Then there is the detailed, non-negotiable list of dietary and behavioral triggers that directly undermine LES tone or just cause chemical irritation.
Right, and this list must be provided in writing. Foods that decrease LES tone include fatty or fried foods, because fat slows gastric emptying. Chocolate, peppermint, caffeine, and alcohol.
So a lot of the good stuff,
A
unfortunately.
lot of the good stuff. Then you have the direct irritants that are acidic in nature, like citrus fruits and tomato-based foods, pasta sauce, pizza. Beyond diet, patient teaching must rigorously include smoking cessation, as nicotine directly lowers LES pressure.
Okay.
Furthermore, patients must be taught to avoid behaviors that acutely increase intra-abdominal pressure. Wearing tight clothing and bending, lifting, or straining immediately after eating. Weight management is also vital.
Right, because central obesity puts constant pressure on the stomach.
Constant pressure.
If lifestyle modification isn't sufficient, we move to drug therapy. Antacids offer quick neutralization, but they don't last long.
They're a temporary fix.
Right. H2 receptor blockers, like famotidine, they reduce acid secretion and are effective for mild symptoms or nocturnal reflux. But the proton pump inhibitors, the PPIs, those are the big guns.
PPIs, omeprazole, pantoprazole, and so on are the most effective therapy for moderate to severe GRD and are the drug of choice for promoting the healing of erosive esophagitis.
And their mechanism is just incredibly powerful.
It is. They block the proton pump, which is the final common pathway of acid secretion, resulting in maximal acid suppression. A key teaching point for efficacy is that they must be taken before the first meal of the day for optimal systemic suppression.
But for the astute learner, the long-term use of these powerful drugs carries recognized risks. This requires vigilant monitoring and patient teaching. What are the key complications emphasized in clinical practice regarding chronic PPI use?
The clinical literature, and specifically the Lewis framework, emphasizes 3 major long-term risks. We need to ensure patients understand this trade-off. First, chronic PPI use is linked to an increased risk of osteoporosis-related fractures.
Really, in the hip and spine.
Particularly in the hip and spine, likely due to impaired calcium absorption in a less acidic environment. This is a huge concern for geriatric patients.
And the connection to infectious disease is fascinating. How does reducing stomach acid open the door to dangerous pathogens?
Well, by drastically suppressing stomach acid, we remove the body's first line of defense against ingested bacteria.
Makes sense.
And this results in a heightened risk for C. difficile infection. The nurse has to educate the patient to report any unexplained, severe watery diarrhea immediately, as C. diff is highly contagious and can be life-threatening.
And the third risk?
The third risk is the development of vitamin B12 deficiency. Stomach acid is required to cleave B12 from the proteins in food, allowing for eventual absorption. So long-term PPI users need regular screening for B12 levels and may require supplementation to prevent neurological deficits and pernicious anemia.
So if a patient fails maximal medical management and rigorous lifestyle changes, when do we accept that the LES just can't be fixed by pills alone? That's when we talk about surgical interventions, specifically the Nissen fundoplication.
The Nissen fundoplication is the classic surgical fix. It involves taking the upper part of the stomach, the fundus, and wrapping it 360 degrees around the lower esophagus, suturing it in place to create a reinforced, tighter LES.
Okay.
Indications for surgery include severe symptoms refractory to medicine, severe complications like strictures, or a patient just desiring to stop lifelong medication dependency.
And postoperative nursing care is paramount here, especially managing the expected changes in swallowing and digestion.
Absolutely critical. Initial dysphagia is expected for several weeks as the esophagus adjusts to the reinforced valve. We need to reassure the patient this is normal, but also monitor for any worsening.
And what about the gas bloat syndrome?
That's a big one. More distinctively, patients frequently experience gas bloat syndrome. Because the new tight sphincter is so effective at preventing reflux, it also prevents the patient from effectively belching or venting swallowed air.
So they get really uncomfortable.
Profound abdominal pressure and discomfort. Therefore, immediate postoperative teaching includes the absolute avoidance of carbonated beverages, chewing gum, and gas-producing foods to prevent acute, severe distension.
Okay, so if GARD is the failure of the gate, peptic ulcer disease is a failure of the protective barrier itself.
Right.
PUD is defined by the erosion of the GI mucosa, resulting from the digestive actions of hydrochloric acid and pepsin. It is, at its core, a major imbalance between protective factors like mucus and bicarbonate and the hostile factors like H. pylori and NSEs.
And the key mechanistic takeaway is that ulcers only develop when acid is present. The stomach relies on this multi-layered defense system. When that protective barrier is compromised, usually a localized defect acid penetrates back into the mucosa, causing cellular injury, inflammation, and local chemical burns.
And then the self-perpetuating vicious cycle begins, worsening the injury.
Exactly. The damaged mucosal cells release inflammatory mediators, particularly histamine.
Histamine.
And the local effect of histamine is twofold. It causes local vasodilation and increased capillary permeability, leading to edema. But critically, histamine also stimulates the parietal cells to secrete more acid and pepsin.
Which just worsens the initial injury and deepens the ulceration.
Right. This positive feedback loop is what makes ulcers persistent and so difficult to heal without intervention.
So let's identify the key factors that cause this impairment of the mucosal barrier. The primary biological culprit is H. pylori.
Helicobacter pylori is a spiral-shaped bacterium that is highly successful at colonizing the gastric environment. It produces an enzyme, urease, which breaks down urea into ammonia.
And the ammonia is the problem.
The ammonia buffers the stomach acid immediately surrounding the bacteria, allowing it to survive, but the ammonia also causes chronic inflammation and damage to the mucosal cells, leaving the tissue highly vulnerable to acid attack.
And second, the most common medication-related cause? Chronic NSAID and aspirin use.
Yes. NSAIDs, nonsteroidal anti-inflammatory drugs, inhibit the synthesis of protective prostaglandins.
And these prostaglandins are indispensable.
Absolutely. They maintain the integrity of the mucosal barrier, they stimulate mucus and bicarbonate secretion, and ensure adequate blood flow to the lining. When NSAIDs block these protective functions, the barrier becomes instantly permeable, leading to rapid ulcer formation.
And finally, the role of stress in the nervous system.
Chronic stress or anxiety increases vagal nerve stimulation, which directly triggers the parietal cells to increase HCl secretion. Now, stress doesn't cause ulcers alone, but the prolonged exposure to hyperacidity, especially in the duodenum, can overwhelm the natural protective mechanisms, leading to chronic ulcer development.
And corticosteroids can make it worse.
They can compound the problem by decreasing mucosal cell renewal.
So the attack plan for PD requires a coordinated strike, reducing the hostile acid factors and eradicating the bacterial culprit.
The treatment requires a combination approach. We use PPIs and H2 blockers to suppress acid maximally. But to tackle the source, we have to eradicate H. pylori if it's present. This is usually done with a triple or quadruple therapy regimen.
A lot of pills.
A lot of pills, often including a PPI, plus 2 or 3 antibiotics like amoxicillin, clarithromycin, or metronidazole, sometimes incorporating bismuth. The nurse must stress the importance of patient adherence to this multi-drug regimen.
Because if they don't finish it,
Non-completion is the primary driver of treatment failure and antibiotic resistance. And of course, eliminating NSAs and encouraging smoking cessation is also non-negotiable.
now we move from chronic management to acute crisis. When PD, which is essentially a hole in the lining, erodes deep enough, it results in critical complications that demand immediate expert intervention.
Right.
We must focus on these as they are the direct triggers for the code blue.
So the first and most common complication is hemorrhage. The ulcer erodes into a blood vessel beneath the mucosa. Clinically, we assess for hematemesis coffee ground or bright red and melena, but the true nursing focus is on detecting and treating the resulting shock.
We have to reiterate that critical nursing alert regarding systemic hypervolemic shock.
Absolutely. The clinician tracks the hemoglobin and hematocrit, but those values may not drop immediately due to hemoconcentration.
That's a key point.
A huge point.
Mm.
The nurse must recognize that tachycardia, a heart rate over 100, is often the first sign of compensatory shock. Hypotension is a late decompensatory sign.
By the time the patient is hypotensive, they've lost a significant amount of blood.
25% or more of their circulating blood volume. Immediate securing of large bore 5E access and rapid fluid resuscitation is the only way to manage this life-threatening event. Hemorrhage is statistically the most common cause of death related to PU.
The second complication is perhaps the most immediate surgical crisis: perforation. This is when the ulcer erodes completely through all layers of the gastric or duodenal wall, spilling highly acidic, infectious contents into the sterile peritoneal cavity.
Perforation is a devastating surgical emergency. Mortality rates climb rapidly if intervention is delayed. This is the ultimate aha moment in assessment.
Okay.
The patient experiences sudden, excruciating, unremitting abdominal pain. The nurse's physical assessment will reveal a remarkably rigid, board-like abdomen.
A board-like abdomen?
This rigidity is involuntary muscle guarding in response to the massive chemical and bacterial irritation of the peritoneum, known as peritonitis.
And what about the referred pain?
Yes. Irritation of the diaphragm by the leaking contents can cause classic referred pain to the shoulder or back. Intervention is immediate. Nothing by mouth NPO large bore IVs for stabilization, preparation for emergency surgical repair, and aggressive pain management while stabilizing the patient.
And the risk of sepsis is huge.
The high risk of sepsis from bacterial contamination means time is measured in minutes.
Shifting to a complication that develops more gradually, we have gastric outlet obstruction, GOO, or pyloric obstruction. This is often caused by chronic edema, inflammation, or scarring at the distal stomach or pylorus.
Right. Assessment for GO focuses on the mechanical blockage symptoms. The classic presentation includes nausea and persistent profuse vomiting. A key observation is that the vomit often contains undigested food consumed hours or even the previous day because the gastric contents just cannot pass.
And they feel full quickly.
Exactly. Patients report early satiety, bloating, and noticeable weight loss due to inability to tolerate food.
And this is where the acid-base chemistry becomes profoundly important. We see a unique electrolyte imbalance that must be addressed before surgery can even be considered.
This is a crucial teaching point for the learner. Because the patient is vomiting large amounts of acidic gastric contents containing high concentrations of HCl, they are rapidly losing hydrogen ions.
Okay.
The resulting imbalance is characterized by dehydration, decreased potassium levels, and critically metabolic alkalosis.
Let's elaborate on why that metabolic alkalosis occurs. Connect it back to the body's attempt to compensate.
So as the patient loses H ions rapidly through vomiting, the kidneys attempt to compensate by retaining sodium and exchanging it for potassium, which leads to the hypokalemia.
Right.
More importantly, the kidneys retain bicarbonate to buffer the loss of acid, driving the blood pH up, alkalosis. If this is not corrected with fluid resuscitation and replacement of electrolytes, the patient can suffer severe cardiac complications.
So what's the nursing care?
Nursing care involves decompression via NG tube, aggressive fluid and electrolyte replacement, and eventually endoscopic dilation or surgery to open the strictured pylorus.
Finally, we revisit the teaching needed to prevent recurrence of all these crises.
Non-adherence is the #1 enemy of PUD management. The teaching has to be direct. Complete the H. pylori antibiotic regimen fully, regardless of symptom improvement.
No stopping early.
Absolutely not. Absolutely avoid all NSAIDs and ASA unless medically essential, and eliminate tobacco use immediately. The patient must understand that vigilance is the key to preventing the next potentially fatal hemorrhage or perforation.
Now I transition from mucosal erosion to true vascular catastrophic bleeds. Esophageal or gastric varices are the definition of a rapid, massive, life-threatening upper GI bleed.
They really are.
What's the underlying cause, and why are these structures so prone to rupture?
Varices are dilated, engorged, highly fragile veins that develop primarily in the distal esophagus and proximal stomach. They occur because normal blood flow through the liver is obstructed, in 90% of cases, due to portal hypertension secondary to advanced cirrhosis.
So the liver is scarred and blocked.
Exactly. When liver scar tissue blocks the flow, pressure builds up, shunting blood into collateral veins that are not designed for high pressure. Their walls become thin, ballooned, and extremely susceptible to rupture.
And when a varix ruptures, the assessment finding is overwhelming and demands immediate critical care activation.
The clinical hallmark is hemanaphysis of massive amounts of bright red blood. This is usually accompanied by immediate and profound signs of decreased perfusion.
This patient is coding.
The protocol is immediate ICU admission, simultaneous intervention, and massive resuscitation.
What does that immediate intervention package look like, especially focusing on pharmacological intervention?
Nursing priorities are aggressive and simultaneous. Securing the airway, often requiring rapid intubation to protect the lungs from aspiration. Placing 2 large-bore IVs or a central line, massive fluid resuscitation, and immediate blood product transfusion.
Okay.
Pharmacologically, we administer vasoconstrictors like octreotide.
For the learner, why is octreotide the specific drug of choice here? How does it work?
Octreotide is a synthetic analog of the hormone somatostatin. It works by causing selective splanchnic vasoconstriction. It clamps down on the blood vessels feeding the portal system.
Ah, so it reduces the inflow.
Exactly. This effectively reduces the blood flow into the portal vein, which decreases the pressure inside the varices, slowing or stopping the bleeding without causing severe systemic hypertension. Long-term prevention after stabilization often involves non-selective beta blockers to generally reduce portal pressure.
Let's contrast that rapid, massive bleed with the Mallory-Weiss tears, which are mechanical tears often seen in a specific clinical context.
A Mallory-Weiss tear is a laceration of the mucosa at the gastroesophageal junction. It's caused by the sheer mechanical force of severe retching or violent vomiting.
And we see this a lot with alcohol.
Very common in patients with acute alcoholic intoxication or chronic vomiting associated with bulimia, where the pressure gradients just become overwhelming.
Since the bleeding is often less catastrophic than varices, the intervention can be more direct.
Exactly. Bleeding often stops spontaneously. If it persists, endoscopy is used for both diagnosis and therapeutic cauterizing or clipping of the tear. But the crucial patient teaching focuses on addressing the underlying cause. Managing the triggers for vomiting, most commonly severe alcohol intake, is essential to prevent recurrence.
Okay, moving beyond the ligament of Treitz, we now shift our focus to lower GI bleeds. These are often characterized by hematochezia, bright red blood per rectum, and present distinct management challenges. Let's start with the most common source, diverticular disease.
Diverticular bleeding is the most common reason for lower GI hemorrhage. A diverticulum is a small, saccular outpouching of the intestinal mucosa through the muscle layers. It typically occurs at weak points in the colon wall, most often in the sigmoid colon.
And we need to distinguish between two phases of the disease.
We do.
So define the difference between the non-inflamed condition and the acute crisis.
So diverticulosis is the presence of multiple non-inflamed diverticula. Patients are usually asymptomatic or report vague symptoms like bloating or alternating constipation and diarrhea. The bleeding that occurs here is due to erosion of small vessels near the diverticular sac and is usually slow, chronic, and dark.
Okay, and diverticulitis.
Diverticulitis, conversely, is the acute inflammation. It happens when retained stool and bacteria get trapped in a diverticulum, forming a hard mass called a fecalith, causing local ischemia, microperforation, and inflammation.
What are the key assessment findings for a patient presenting with acute diverticulitis?
Assessment findings include abdominal cramps, usually localized over the affected left lower quadrant, alternating bowel habits, and systemic signs of infection, fever, chills, and leukocytosis.
And the primary goal is to prevent perforation.
The primary nursing goal is to prevent perforation and peritonitis. Acute management requires aggressive nursing intervention to completely rest the bowel. The patient is immediately placed on NPO status.
Okay.
This is coupled with IV fluids to maintain hydration and circulation, and aggressive, broad-spectrum IV antibiotics to treat the localized infection and prevent abscess formation.
And if that doesn't work?
If the inflammation or perforation cannot be controlled medically, a colon resection may be necessary. Patient teaching focuses heavily on high-fiber diets once the acute episode resolves, though not during the acute flare.
Right. Now, we must consider ischemic bowel disease, which is a terrifying perfusion problem where blood flow to the intestines is suddenly or chronically blocked.
It's a true emergency.
What causes this oxygen starvation in the gut?
Ischemic bowel disease stems from insufficient oxygen delivery. The causes are diverse, but usually involve either a mechanical blockage, like a thrombus or embolus, completely shutting off a mesenteric artery, which is acute mesenteric ischemia, or a low flow state where cardiac output is insufficient to supply the gut.
And you see that in shock or severe heart failure.
Exactly.
The assessment finding for acute mesenteric ischemia is considered a clinical pearl because the pain doesn't match the physical findings.
That is the critical distinction. Patients present with sudden, excruciating abdominal pain that is dramatically out of proportion to what the physical exam findings suggest.
Out of proportion.
The high level of pain is caused by the profound hypoxia and subsequent death of the intestinal tissue. However, the abdomen often remains soft initially because the inflammation hasn't yet spread to the sensitive peritoneum.
So the high pain, low findings combination is because the gut is being strangled of oxygen, but the major inflammation and rigidity haven't fully set in yet.
Precisely. That is the critical window. If ischemia persists, it leads quickly to necrosis, perforation, and peritonitis. Treatment is centered on the rapid restoration of blood supply, aggressive fluid resuscitation to optimize perfusion, measures to increase cardiac output, antibiotics, and often immediate emergency surgery to remove any segments of dead bowel to prevent fatal septic shock.
Moving on to the chronic inflammatory conditions, ulcerative colitis and Crohn's disease, the distinction in their pathology dictates the symptoms and the specific complications we watch for. Let's start with ulcerative colitis.
So UC is a chronic IBD that is confined to the large intestine. The key pathological feature is that the inflammation is superficial, limited to the mucosa and submucosa.
And it follows a continuous pattern.
A continuous pattern, always starting in the rectum and spreading proximally. The resulting ulcerations destroy the mucosal epithelium, which leads directly to bleeding, exudate, and profuse diarrhea.
And the hallmark assessment finding for UC that guides the clinician.
The absolute non-negotiable hallmark symptom is bloody diarrhea. Depending on the severity of the flare, this can range from a few semi-formed bloody stools to 10 to 20 liquid, bloody, mucus-containing stools per day in a severe crisis.
Wow.
Systemic symptoms in severe cases include debilitating fever, significant unintentional weight loss, anemia due to chronic blood loss, and profound dehydration.
And what is the most critical, life-threatening intestinal complication we must screen for?
Toxic megacolon. This is an acute, life-threatening inflammation of the entire colon wall that results in extensive dilation and paralysis of the colon.
So it just stops working.
It stops working, and it carries an extremely high risk of perforation and rapid mortality. Nurses must monitor these patients obsessively for severe, constant abdominal pain, high fever, signs of shock, and leukocytosis. This is a red flag for immediate surgical intervention.
Contrast that sharply with Crohn's disease, where the pathology involves all layers of the bowel.
Yes. CD is a systemic autoimmune disorder characterized by transmural inflammation. It involves all layers of the bowel wall, often causing swelling and thickening. It's unique in that it can affect any part of the GI tract, from the mouth to the anus.
And it's not continuous?
It's not. Its appearance is characterized by skip lesions, where disease segments are interspersed with areas of completely normal bowel, giving the lining a rough, cobblestone appearance.
How does the location and depth of inflammation change the patient's clinical manifestation compared to UC, especially regarding stool?
The diarrhea in Crohn's disease is usually non-bloody, which is a key differentiator from UC.
Non-bloody, okay.
The inflammation is patchy and deeper, leading to cramping abdominal pain, often centered around the umbilicus or the right lower quadrant if the ileum is involved. The patient may also present with nonspecific early complaints like fatigue, low-grade fever, and significant weight loss.
And the most important complication resulting from that transmural deep inflammation.
The depth of inflammation leads to the two cardinal complications unique to Crohn's, strictures and fistulas.
Right.
Chronic scarring narrows the lumen, creating strictures and leading to frequent bowel obstruction. And fistulas are abnormal connections that bore through the bowel wall to connect the bowel segment to other organs, like the bladder or vagina or the skin.
And the specific nutritional deficiency related to Crohn's?
Because CD commonly affects the terminal ileum, where bile salts and certain vitamins are absorbed, malabsorption is a major issue. This leads specifically to deficiencies of fat-soluble vitamins A, D, E, and K, often requiring aggressive nutritional supplementation and patient education.
General management for both IBDs during an acute flare requires aggressive medical support and bowel rest.
During a flare, management involves IV fluids, potential blood transfusion for chronic anemia, placing the patient NPO, and utilizing medications such as high-dose corticosteroids to rapidly suppress inflammation. Long-term management relies on sophisticated pharmacological regimens and frequently surgery.
Okay, finally, we must briefly cover colorectal cancer, or CRC, as a critical insidious bleed source. Most CRCs are adenocarcinomas, beginning as small, benign adenomatous polyps in the mucosal lining.
That's right.
What is the path of metastasis that clinicians need to understand?
Once these tumors become malignant and invasive, they penetrate the muscularis mucosae and metastasize. Cancer cells commonly enter the regional lymph nodes and blood vessels, spreading primarily to the liver via the portal venous system and the lungs via the inferior rectal vein.
Since CRC symptoms are often nonspecific early on, what are the subtle assessment findings that should prompt immediate investigation and screening?
Early detection relies heavily on screening, but when symptoms appear, they often relate to obstruction or chronic blood loss. We look for rectal bleeding, which may be visible hematochezia or occult. Hidden, detectable only by fecal blood tests. Crucially, we assess for persistent changes in bowel habits, such as alternating constipation and diarrhea, and a key mechanical sign of a growth is the passage of narrow or ribbon-like stools.
And the systemic symptoms of that chronic, slow bleeding.
Unexplained lethargy, fatigue, and profound iron deficiency anemia. These systemic signs are often what trigger the definitive diagnostic workup, which is typically a colonoscopy. Nursing intervention focuses on preparation for diagnostic procedures and, depending on the stage, preparing the patient for surgery, chemotherapy, and radiation.
This final section is the synthesis of everything we've discussed, focusing intensely on the immediate clinical response required when any of these conditions, whether it's a PUD hemorrhage or ruptured varices, results in a life-threatening hemorrhage.
Right. This is the critical care checklist that has to be executed simultaneously and rapidly. For any acute massive GI bleed, the immediate top-tier priorities must be secured within minutes.
Which are?
First and foremost, maintain airway and breathing. If it's an upper GI bleed with massive hematomesis, the risk of aspiration is extremely high. The patient must be rapidly intubated if their level of consciousness or gag reflex is impaired.
Number one is airway, always.
Always. Second, rapid fluid resuscitation. We need to secure at least 2 large-bore IV lines, ideally 16 or 18 gauge, and administer crystalloids like normal saline immediately to stabilize volume while awaiting blood products.
And the third priority speaks directly to restoring oxygen carrying capacity.
Blood transfusions. If the patient is unstable or actively bleeding with a falling hemoglobin, packed red blood cells must be administered as quickly as possible. In cases of massive transfusion protocols, we also often include fresh frozen plasma and platelets to correct coagulopathy. This aggressive, rapid replacement is the cornerstone of survival.
While that rapid stabilization is underway, interventional strategies move quickly, primarily relying on endoscopic procedures.
Endoscopy serves a dual purpose: diagnostic confirmation and immediate treatment. For vascular lesions like varices, intervention means endoscopic band ligation or sclerotherapy.
So you're stopping the bleed at the source.
Right at the source. For bleeding ulcers or tears, it's therapeutic cauterizing or clipping the bleeding point. In specialized cases, for persistent lower GI bleeds caused by things like AV malformations, interventional radiology may perform intra-arterial embolization, threading a catheter through the vasculature to physically block the blood supply to the bleeding site.
So, for the learner focusing on assessment, interpreting raw lab data in the heat of a crisis can feel like trying to drink from a fire hose. We need a structured, strategic framework for analyzing data in the context of bleeding and shock.
We do, a systemic knowledge tool.
What is that step-by-step framework that guides critical thinking at the bedside?
Okay, step 1. Meticulously record the abnormal and the normal results. Don't assume anything. Step 2. Focus intensely on trends and onsets.
Okay.
A hemoglobin that has slowly dropped from 14 to 12 over 6 months is a completely different clinical scenario than a hemoglobin that drops from 12 to 8 in 2 hours. That trend dictates urgency. Step 3. Develop a list of hypotheses. Why is the patient tachycardic? Is it bleeding? Is it fever? Is it pain?
And then filtering and synthesizing that information to reach the clinical conclusion.
Right. Step 4. Rule out what doesn't fit the clinical picture. For example, if the patient is bleeding profusely, but the initial HGB and HTT levels don't reflect major loss, remember that it often takes 24 to 48 hours or significant fluid resuscitation for the hemoelution to occur that fully reveals the true extent of the blood loss.
So the initial labs can be falsely reassuring.
Exactly. Step 5, and most importantly, look at all the data synergistically. A low HGB-HTT is alarming, but when paired with rising heart rate, falling blood pressure, and perhaps that metabolic alkalosis we discussed earlier, the synergy points definitively to a diagnosis and guides the intervention.
Hypovolemic shock.
Hypovolemic shock with ongoing GI loss, combined with the cause of the electrolyte imbalance. Step 6, and finally, provide your interpretation, connecting the data back to the patient's immediate physiological status. This systemic, integrated approach is the difference between simply reporting data and guiding treatment.
This has been an incredibly detailed look at the full spectrum of GI bleeds. For you, the learner, the key takeaways are clear. First, master the anatomical distinction and the associated presentation melena for upper, hematochezia for lower, and the critical nuance of coffee ground emesis. Second, recognize the non-negotiable signs of a surgical emergency, like the rock-hard, board-like abdomen of PUD perforation or the severe abdominal pain out of proportion to exam findings in acute mesenteric ischemia.
And never forget the critical role of patient teaching. The difference between chronic management success and recurrent crisis rests on detailed lifestyle modification for GRD and the absolute necessity of compliance with H. pylori eradication and avoidance of NSAIDs.
That's so important.
We covered diverse etiologies today: ulcers, fragile varices, chronic inflammation, and cancer. But the most important synthesis is that while the causes vary wildly, the immediate management priorities in the acute setting airway protection, securing perfusion, and rapid diagnosis remain constant across the board. The clinical focus must always be on maintaining hemodynamic stability first.
Absolutely. And as we discussed chronic inflammation in IBD, we noted that it can lead to profound systemic issues called extraintestinal complications, problems with the skin, joints like arthritis, and the eyes, uveitis that seem unrelated to the gut.
Yes.
Considering this profound and sometimes surprising interconnectedness, what other seemingly non-GI symptoms, like a persistent rash, sudden unexplained joint stiffness, or unusual eye inflammation, might warrant a deeper systemic look into the digestive tract's underlying health and inflammatory status?
That's a great thought.
Something for you to mull over as you integrate this new comprehensive knowledge. Thank you for supplying the sources for this deep dive. We'll catch you next time.